The hand instruments, the reusable hand instruments, most of the laparoscopic hand instruments are 4 sizes are available: 20 centimeter, 28 centimeter, 36 centimeter, and 45 centimeter. 20 centimeter is used for the junior pediatric patient, like less than 5-year age group children. The 28 centimeter for senior pediatric, from 5-year to 14-year-old children, the length of your instrument should be 28 centimeter. 36 centimeter, these are 36 centimeter instrument, which is used for adult, and 45 centimeter length instrument is used for bariatric patients. So these are the length of the instrument which is generally used. Now the question is, why not we should just buy one bariatric set of instrument, that is 45 centimeter, so that we can use in every case, and we don't have to change for the 32, 36, 28. The reason is that if you will use a longer instrument in a small abdominal cavity, then it will work as a type 2 lever. There are 3 types of lever: type 1, type 2, type 3. Type 1 lever is balance. Balance is used to weigh the things. Shopkeepers, they are using the balance. Exactly same way, in our abdominal wall act as a fulcrum, and the length of the instrument which is inside the abdomen is called as load arm, and the length of the instrument which is outside the abdomen, it is called as force arm. And abdominal wall act as a fulcrum, and our instruments are acting as a lever action. So suppose you have a very long instrument for a small child, then maximum length of the instrument will be out. So if the maximum length of the instrument is out, your force will be force will be magnified and movement will be rectified. Like, let us see, if this is the instrument and this is the abdominal wall and only little length of the instrument is in, then if I am moving outside 10 centimeter, inside movement is only 2 centimeter. So movement is rectified and force will be magnified. If I will apply 5 Newton inside, there will be a big force. That's why, type 2 lever is used by engineers to drag the heavy object. You might have seen, suppose some tree or some big stone is fallen in front of your house. If they have to move that object away, they are using type 2 lever. How they bring a bamboo or a big rod, and suppose they want to drag this object, they put a fulcrum here, very near, and then they can drag it like that. Even a weak person can drag the heavy object if they will make type 2 lever. And movement will be very slow. In one time, only few inches that heavy object will be dragged. But it can be pushed by the less force also. So in type 2 lever, force is magnified and movement is rectified. And that is very inconvenient in laparoscopy. So ideally, our laparoscopic instrument should behave like a type 1 lever. In type 1 lever, fulcrum is in the middle, so that force and movement is equal and opposite. And that's why we have the 4 sizes of the instrument available: 20 centimeter, 28 centimeter, 36 centimeter, and 45 centimeter, according to the size of the abdominal cavity. Sometimes if you are using the retroperitoneoscopy or totally extraperitoneal hernia surgery, then we have only 18 centimeter instrument, so that 9 centimeter is in, 9 centimeter is out. Because suppose you are doing retroperitoneoscopy and you will use 36 centimeter instrument, then it can prick or it can perforate the peritoneum also. Now every instrument has 3 parts. One is called as handle, other is called as insert, third is called as sheath. So I will demonstrate you. So the flower hata dena. If you will remove the cap like that, here I am removing the cap. This cap is removed. After that, handle, open the handle and handle will become separated. This is handle of the instrument. Now, here is the insert. If you will remove like that, this is insert. This is insert. Insert means what is inside? The sheath. And this is sheath. The sheath has a insulation. It is insulated. So these are the three parts of laparoscopic instrument. This is handle, this is insert, this is sheath. And it is changeable. Insert of one you can change with the handle of another, with the sheath of the third one, if it is of same company. The advantage is that if it is three part, every time after surgery you have to open it to clean. In the assembled state it should not be cleaned. First you should disassemble it and then you clean it. Suppose the insulation is breached here or insulation is broken, then if you want insert of another and sheath of the good one, you can interchange. Or suppose this insert has the grasper, seizure, different type of jaw. Suppose it is broken, I can order the company that send me a insert of scissors. I don't have to pay for entire instrument. So it will be very much economical also. Ratchet is there sometime. In some of the handle there is a ratchet. But suppose I don't want ratchet, then I can change the unratchet handle of someone and I can change the ratchet with another. Like scissors, you will never like to have ratchet, isn't it? Scissors, no need of ratchet. Maryland, no need of ratchet. But suppose you want in the bipolar, or if you want with the grasper, you can attach it. So again I will show you how to assemble it. To assemble it, you have to open the handle first. As soon as you will open the handle, one socket will come out. And you put the insert into sheath and then open the handle. And in the handle, there is one socket, and here in the insert there is one ball, just like the soldier joint. So this ball should go to this socket and then close the handle. Automatically ball will pull the socket in and then put the cap, and that's all. It is assembled. This is a hardly few second job. Every time after surgery, your nurse should open it, disassemble all the three pieces with the running water, tap water with some detergent. Mild body shampoo can be used. Any body shampoo can be used with the sponge to clean it, with tap water, and then you put in the Sidex. Ideally, companies are recommending that even in the Sidex you should put it into the disassembled state. But generally we don't do that. Do you know why? Because unnecessarily in the tray, if you are living for a long time, all will mix together. Handle of one, insert of another, and then it is sometime if one instrument is of one company, other instrument is a Star, third instrument is Olympus, fourth instrument is Indian, now it will not fit. But if you have all the instrument of one company, you can put in the Sidex in the disassembled state also. So every instrument nowadays, some of the instrument cannot be disassembled, like bipolar. Do you know why? Can I have this? This is bipolar grasper. And it cannot be disassembled. Why? Because it has two wires coming inside, and both the wires are giving two pole attachment here. So you cannot open it. If you try to open it, it may break because wires are there. So in those situations, like needle holder, you cannot open it. Needle holder is rock solid hard, and here you cannot. Every day you can open it. If you open it, it will become loose because the jaw should be rock solid hard to hold the needle. So any instrument which you cannot dismantle, they have given one channel to clean it. This channel is for cleaning. So what you need to do, take a saline and with some mild detergent and fix it and flush it. so that any blood clots or the tissue or the fat cell which is trapped into the channel will be washed out. So in some instrument where you cannot disassemble, you have the channel for cleaning. Yes?
So if the insulator by chance is scratched or broken, can be used? Or?
No, it should never be used. It is a broken insulation they call. It is important that we should inspect the insulation very carefully, because that may be very dangerous and it can create insulation failure, can create burn.
If you're not using any energy sources,
then it will not work, then it will not have, because energy only, suppose this is the uninsulated part. Here, these are the insulation failure. Sorry, some insulation failure is at the tip also, but here is also insulation failure. So if you are attaching like that and bobble is touching this will burn. That I will explain in detail during the energy sources. Not only that, it can create direct coupling also. Suppose you see uninsulated part is touching the telescope, then the current will go to telescope. Your telescope is uninsulated and telescope somewhere is touching. If the bowel, that also will burn. So it can create big problems. So how to avoid it? There are two ways of avoiding the insulation failure. One way is inspect the insulation carefully, either by magnifying lens or very carefully by naked eye. Other way is, if you can afford, you have to buy one AEM system. That is called as active electrode monitoring system. There is one electronic circuit that is called as AEM. If you attach your generator, and nowadays a good expensive machine already is equipped with the AEM system. So if the insulation failure, direct coupling or capacitive coupling is happening, it will give you the warning there. It will write that your instrument insulation is failure. Yes.
Well, stop the machine.
Stop the machine, and it will give you the warning that you should change your instrument. So those you can use technology. If you don't have technology, then you have to be more careful. Yourself you have to be careful. If you have technology, then it will sense its own. So this was regarding. Now the first instrument which I am going to discuss in the hand instrument is atraumatic grasper.
So just 1 minute. So you told that you have to clean this bipolar and needle holder through using which detergent?
Any mild body shampoo can be used. Like any detergent, like simple mild soaps you can use. Or sometimes any shampoo which we use to clean our hair or the body can be used.
That can be pushed with this syringe?
Yes, yes, with the diluted.
So if the instruments are of the same company, then even if the sheath is interchanged, it will not be...
It will not harm. It will go to one to another. And actually cleaning itself is a very much expensive. Many people, they can use the enzymatic cleaner. And if you ultrasonic cleaner, there are a lot of variety of the cleaning of the instrument. Ultrasonic cleaners are so good that it is only water, you have to put it and it vibrates at 55,000 vibration. Each and every dust particle will come out. And all the blood clots, and it will dislodge immediately. Enzymatic cleaners people are selling. That is, it will, even the blood clot, it will digest, it will get completely dissolved. And it is 2,500 rupees for one time cleaning. But the problem with the cost also we have to see. So generally, if you want to minimize the cost, just tape water, running water, with the mild detergent and with the sponge, you can just rub it and it is clean. And because cleaning must be there before putting into the sterilizing Cydex. Because if it is already blood stained and all, if you put in the Cydex, it will not work. And moreover, within 2-3 times only, your entire Cydex solution will turn into black. Remember, Cydex has two things: one 15 times, another 15 days, and third, it should not become opaque. Generally transparent, it is transparent. After putting in the Cydex, all the instruments should be visible. Isn't it? But if it is, all the instruments are dirty, after 2-3 times it will become black, then you have to discard it, change it. Because no more it will be potent, it will be completely lost the capacity. So the first instrument which I am going to discuss is the atraumatic grasper. Atraumatic grasper, the definition is, it is double action jaw, fenestrated, low sedation grasper. Double action jaw, fenestrated and low sedation. You know, laparoscopy, there are two types of instruments. One is double action jaw and other is single action jaw. If you see, this is single action jaw. Means only one jaw is opening. Isn't it? बस आप बबल एक आदमी शिवलाल तुम उधर चले जाओ, एक एक इंस्ट्रूमेंट जो भी हम यहाँ दिखाते हैं उन लोगों को भी दिखाते हैं, तुम यहाँ रहो इन लोगों को दिखाने. So you have two type of instrument. One is single action jaw and this is double action jaw. The double action jaws are weaker instrument because they have three joints. Three joint. उधर से single action jaw दिखाओ, double action jaw. So if you see carefully, this double action jaw, here is one joint. For this jaw there is one joint here, and for this jaw there is one joint here. Isn't it? So there are three joints here. In the middle there is one. Repeat, and if you very carefully, one joint here and other joint other side. Isn't it? So due to three joint, it is inherently loose. See, the jaws are not very rock solid hard. So double action jaw, you cannot make a needle holder with a double action jaw. You cannot make a very strong instrument like claw forceps, stone holding forceps. Cannot be double action jaw. Like this is a stone holding forceps. It cannot be double action jaw. It should be single action jaw. This is needle holder. This is needle holder. And you know, in single action jaw, you have only one joint. Here there is one rod and there is one cylinder. And there is only one joint. Can you see that?
Yes.
Only on one joint it is moving. So it is very strong. Double action jaw should never be used to enucleate the myoma and all. If you want to do myomectomy and you want to separate the myoma with the uterus with the double action jaw, jaw will break. But single action jaw will not break because it is a single piece and it cannot break. So,
double action for dissection, right? Can dissect.
yes, for dissector, double action jaw has the advantage, it gives you more surface area. But to hold, it is not very strong. So that's why atraumatic grasper is double action jaw and fenestrated. Fenestrated means there is a hole into. And this is fenestrated. What is the advantage of fenestration? That tissue can breathe inside. And low serration. Serration means if you see inside the jaw there is serrations. And serrations is only 0.1 millimeter. Means the depth of the serration is less than 1/10 of a millimeter. So the advantage is it doesn't harm the tissue. Just like I will hold, just and I am giving it this grasper and I am putting my thumb. Yes, and press it. Press as much as you can. Press more. Apply. I am not crying. See? Press more as much as you can. No, never mind. Press. See, I am not crying. But my finger is deformed. But this is called as elastic deformation. Because if I will do like that, now it is good. Now there is no deformation. This is called as elastic deformation. Elastic deformation means deformation which can be reversed. Another type of deformation is plastic deformation. So atraumatic grasper will never do plastic deformation. Most of the time it should do the elastic deformation. And what is the definition? It is double action jaw, fenestrated, low serration grasper. And this is the instrument which you should introduce first before starting any surgery. Even if you are doing appendicectomy, cholecystectomy, hysterectomy, whatever the surgery, initially during the diagnostic part, this instrument should be introduced. So that you can shift the bowel, you can lift the ovary, you can little bit hold the tube, isn't it? Or you can lift the gallbladder to see that. But it is not good for retraction. It is good for diagnostic purposes or to hold the soft tissue. But if you want to hold the fundus of the gallbladder and push it towards the diaphragm, keep on sleeping. Keep on sleeping. And now it will be frustrating. You hold it and it slips because it is low sedation. So it doesn't hold very tight. In those situations, now next grasper you have to bring, that is called as semi-traumatic grasper. This is semi-traumatic. Semi-traumatic is also double action, but deep sedation without fenestration. Without fenestration means it doesn't have any hole. It doesn't have any hole. And sedations are deep. It is approximately 0.5 millimeter. If you will see there, very deep cut in the jaw is there. Very deep cut is there here. So that it doesn't slip. Even if you will hold the Hartmann pouch or the fundus, it will not slip. And there is no fenestration. So that's why it will create ischemia of the tissue. So semi-traumatic grasper only you should use if you have decided to perform surgery on that tissue.
Is double action?
It is also double action. If you will hold with the semi-traumatic grasper appendix, then you should do appendicectomy. Otherwise, patient may get appendicitis. If you use the normal appendix to hold with the semi-traumatic, there may be inflammation. If you are holding the tube, there may be a stricture. So this should only be used if you have made your mind that I have to remove the tube or I have to remove the appendix, then you are allowed to use semi-traumatic. Fundus of the gallbladder, Hartmann pouch can be used. Now, third one is called as traumatic grasper. This is traumatic grasper. Traumatic graspers are just the replica of our Ellis forceps, which we use in open surgery. So it has 2 to 3 tooth. If you see carefully, the lower jaw has 3 tooth and upper jaw has 2 tooth here. This is just like the tooth forceps or Ellis forceps. So this should only be used on the edematous tissue. It is absolutely not used in the bowel. If you hold the bowel perforates. You are not allowed to use the traumatic grasper to hold the appendix or to hold the small intestine, because bowel will perforate everywhere, peritonitis will happen, fecal matter comes out. You can hold sometime gallbladder, but remember, whenever you are holding gallbladder ruptures and bile leaks. But sometime we have to do that because edematous gallbladder and it is so thick walled that traumatic and semi-traumatics are repeatedly slipping out, or there is empyema gallbladder in those situations. So we are purposefully holding it and it leaks, so we suck it immediately, we clean it. But in the bowel you should not use it. Sometimes in cases of endometrioma for ovarian cyst or for dermoid cyst, when you have to separate the inner cystic layer from outer ovarian cortex, then your hand is repeatedly slipping because it doesn't hold. In those situations, you have to use the traumatic grasper. So this is mostly single action. Mostly it is single action. Although some single action.
And
Single action with the tooth. With the tooth.
there is serration?
No serration. It has a bite. It is biting the tissue. It is purposefully like a tooth to bite it, so that it should not slip out. There is no serration here. Only tooth is there. Although some of the traumatic graspers are double action jaw also, but mostly it is single action jaw. So these are the 3 types of.
It catches only by the tooth, not by the blade.
Yes, only by the tooth, not by the blade. And purposefully it is biting it and perforating the tissue so that it should not slip out. So these are the 3 types of grasper. You know, there are many other names also: dolphin grasper, peacock grasper, Hartmann pouch grasper, fundus grasper. But these names are not necessary to remember, because what the surgeons are using fundus grasper for gallbladder, gynecologists will use for tube, isn't it? And they will tell that it is my fallopian tube grasper. So name should be technically we should remember. We should not necessarily remember the scientist name or the use name, because the same use for urologist is for different purpose, for gynecologist for different purpose. So there are 3 types of atraumatic, semi-traumatic and traumatic grasper.
Maryland, which
Maryland is not a grasper, it's a dissector. I am coming to Maryland now. Now the next instrument is, this is called as Maryland, where they have probably invented into the University of Maryland first. And Maryland is basically a dissector. This is a replica of our artery forceps which we use in open surgery. So it is also double action jaw, but it is pointed and curved just like the hemostat which we use in open surgery. It has three functions. Maryland should never be used for grasping the tissue, because one, it will perforate, it slips also, and it pierces. Just like if you have to hold the fundus of the gallbladder, generally in open surgery you are not using artery forceps. It has three functions. First function is a stripping of the peritoneum. Second function is window formation, and third function is hemostasis. You know, in laparoscopy, most of the surgery starts with the peritoneal stripping. Just like when you are doing cholecystectomy, first you are stripping the peritoneum of the cystic pedicle, isn't it? When you are doing hysterectomy, you are stripping the bladder peritoneum UV fold to separate the bladder. In hernia also, you have to pull the sac and separate it from vas deferens and spermatic vessel. In fundoplication also, you are starting with the pars flaccida or angula fis and stripping the anterior peritoneum over the gastroesophageal junction. So, even in the ovarian cystectomy, you are stripping the outer ovarian cortex from the inner cystic layer. So, wherever you have to do stripping, only Maryland can use, because it can hold even the hair also. See, it is holding. Grasper will slip, but it is very, very strong and can hold even a small hair point. So, you will hold it and you will strip like that. This is stripping. Any other instrument will not do stripping except Maryland. Another is window formation. In laparoscopy, often you have to make a window before clipping, stapling or coagulating. Like if you want to splenectomy, you have to make a window between the splenic artery and vein. Nephrectomy, again cholecystectomy also. Isn't it? Carot's triangle, posterior window, anterior window, all you have to make. For that, Maryland is good instrument. You should open it in the line of the pedicle vessel. Like suppose cystic duct, cystic artery, you should not open at right angle. Otherwise, it can bite or it can pierce. So, this is just like open surgery also. Wherever you have to make a window, what you are using? Artery forceps. You are not using Ellis forceps to make a Carot's dissection. You are using artery forceps. So, window formation in every graspers are not good for window formation because their tip is not pointed. It is broad. So, it will avulge and it will break. Artery also bleeds. So, in those situations, you will use Maryland, because Maryland can give you indentation. This is called as indentation. Indentation means the tip will pierce in the peritoneum and just by opening it will dissect. That's why it is called as dissector, because it can make a window by dissecting the tissue away from each other. Third is hemostasis. Whenever active bleeding starts, this is the only instrument which you will use, and it will go and it will catch the neck of the bleeder. Whenever suppose cystic uterine artery avulged, cystic artery avulged, and spurt started bleeding, then you don't have any option except Maryland. Just like in open surgery also, you are using artery forceps, hemostatic. Graspers doesn't work, and they have fenestration, so it may get a bunch of tissue. And you know, whenever you will hold a bunch of tissue, always there is a chance of remote injury. Because if you are holding a bunch of tissue and coagulating it, current will burn somewhere else. That's why if you will hold by artery forceps or Maryland, it will not burn somewhere else. Why it happens, I will discuss during the dissection techniques. Why the wide jaw instruments are very bad to achieve hemostasis. Because the heat is equal to intensity of the current into time by area. This is the equation. So wherever area is more, heat will be less. So if you will hold with a big surface area grasper, and if you will hold a more surface of the tissue, heat will be less here. And heat will be more somewhere else. That is called as remote injury. But in the Maryland, it is pointed. So if you hold yourself a small area, heat will be maximum where area is small. So heat will be where I am holding, and there will be no remote injury. So that's why in hemostasis you should use only the Maryland. Now there are two types of Maryland. One is monopolar, another is bipolar. This is called as bipolar Maryland, or actually it is called as Robbie Dissector. This is the Robbie was the one laparoscopic surgeon who has invented this first. And this bipolar Maryland is this marketed by the Starch company by the name of Robbie Dissector. Although this is not of a Starch, this is Indian, so you can say it simple bipolar Maryland, because this trade name Robbie is for Starch company. So advantage of this is that doesn't give you the remote injury, because in bipolar, as you know, that current only travels in between jaw. Current doesn't travel through the body of the patient, so there is no chance of remote injury. But it has one drawback. This instrument doesn't last for a long time, because if you see very carefully technically, that there is a joint made up of plastic. This is the bipolar Maryland. In the monopolar Maryland, the joint is made up of metal. But if the joint is of metal, it cannot work as bipolar. Because in bipolar, from the tip of the jaw up to the machine, both the jaws should be separate. It should not get short-circuited anywhere. If it is metal, it cannot be bipolar. So in the bipolar, they are keeping one plastic joint which keeps both the jaw away from each other, so that it can act as a two poles. Both the poles should not get short-circuited. But because this plastic joint is not strong, so it doesn't last for a long time. If you use bipolar Maryland, hardly 10 surgery you can perform. After 10 hysterectomy, you have to change it, because it breaks, and sometimes it will be so loose because of plastic nature. Can you see that? It is very loose joint and it doesn't hold. So this is Robbie Dissector. Just you can pass it to everyone.
So sometimes if the plastic breaks, then anything happens to the patient? But
no, plastic breaks, then it gets short-circuited, and after that it doesn't work.
that's all.
That's all.
It does no harm to the patient.
Harm will be only there if the jaw is broken and it is dropped inside the abdomen. Sometimes it happens. In those situations, carefully you have to take it out. Hold it and take it out. Breaking of the instrument is one of the big problems in laparoscopy. That keep on happening. And in those situations, you have to take it out. So this is now right angle Maryland. Just like sometimes when you have right angle artery forceps, same way this is right angle Maryland. This is nothing fancy, but sometimes it is very useful if you are doing the nephrectomy and all. Like I will just like to show you. So sometimes it is useful that right angle, where it is useful, I will just show you. Here this is nephrectomy. You know, sometimes what happens in nephrectomy, that when you are doing the renal vessels and all, then here this is the dissection started and it is going slowly here. See, this is the renal vein, and here is a harmonic which is a little bit dissected, and this is a suction irrigation. Now in those situations sometimes, if you make a window right angle, you can use the Maryland, which will give you a tip is very easy to visualize. So now it is just dissected and separated. This is right-sided nephrectomy. This is a vein here. Can you see this? This is the right angle. See here, this is vena cava, and this is right angle Maryland. Here, is it clear now? Here, this is opening the jaw. This is the right angle Maryland. So the advantage is, even in the difficult ergonomics, like suppose you want to define the uterine artery or you want to define the renal artery here, this tip is easily visible here. And this is the advantage of right angle Maryland. So this is one of the useful instrument. Sometimes you can use. Cholecystectomy without this also it is okay, because your Maryland curve is also fine. This is not a must-having instrument. If you don't have, then also you can continue. This is monopolar, but sometime if it is there, it will be easy for you. Now the next instrument which I am going to demonstrate to you is scissors. In laparoscopy, scissors are very important. Not why only in laparoscopy, even everywhere scissors is important. This is the scissors who has made you surgeon. Without scissors, you are not surgeon, isn't it? Because surgeons were first barbers. They were cutting the hair of the kings and others. After that, their big persons, they say, okay, this is a skin tag, cut this also. Then they started cutting that also. So slowly they become surgeons. They started cutting more, and now cutting everything. So scissors are very important, and there are 4 types of scissors: curved scissors, straight scissors, the hook scissors, and micro scissors. This is micro scissors, this is straight scissors. So, and this is micro scissors is very small. So, first we should learn how scissors work. Why scissor is cutting? Why scissor cut? Sharp, okay. Another is shearing action. Shearing means one jaw is rubbing over another. And basically it is a lever. It is a type 1 lever, where fulcrum is in the middle and 2 jaws are rubbing each other. This is how scissors work. But scissors work in 4 stages. First is engagement, second is elastic deformation, third is plastic deformation, and fourth is fracture and dislocation. So first and most important part of the scissor, how it works, is engagement. If scissors cannot engage, it is useless. Just like, suppose this is a tube, and I will give this to him. Hold it. And then cut it. I am putting this tube here. If he will cut it, I will give him $100.
Yes.
Cut it.
She is large and the jaw is
You cannot. You also try. Okay. Try. What? Who will hold it? In open surgery, someone will hold it. But laparoscopy, who will hold it? You cannot hold it. In open surgery, what you engage, your nurse is holding it. Because you will hold it and open, and she will push it towards you and cut. And in laparoscopy, who will hold? You will not enter inside the abdomen to hold it. And if you are using any other grasper to hold it very tightly, it may get avulsion, especially suture or proline. So engagement is a big problem. For engagement, it is necessary that the diameter of the jaw, means length of the jaw, should be 8 times bigger than the diameter of the structure. 8 times bigger. Then it will engage. Just like a bigger brass scissors, hold it. And now you don't need to. Engagement is not a problem. Now cut. See? Why it happened? Because jaws are big. So if the contact angle with the scissors is 10 to 15 degree only, it will not slip. Isn't it? Like suppose this is entire table is a wood and my jaws are scissors. If I will go to cut, this will be 90 degree. Then I cannot engage. It will start pushing. But if I will make a scissors which is jaw is of size of this room, then it will not disengage. But in laparoscopy, that much big jaw is not possible to make. Isn't it? You cannot make that much big jaw scissors in laparoscopy. So the problem of engagement is a big problem in laparoscopy. To solve this problem, this hook scissors was invented. In hook scissors, what is there? that the tip is pointed and it cut distal to proximal. It doesn't cut proximal to distal. So problem of the engagement is solved. So now if you will try to cut it, then you don't have problem. You can cut it there. See, this is a hook scissor and he is engaging and it is cut. So, yes. And not only that, it has the advantage that even it can cut partial. Suppose you want to do cholangiogram, or you want to do pyeloplasty. And if you will go like that and you press it, yes, and here cut. See, it is only half of the lumen is cut. Can you see that? And then you can put the ureteric catheter and you can put the dye and you can do the cholangiogram.
How can you make it half cut?
Half cut, just you go and try to catch only the half of the lumen like this. If accidentally you are holding full, then don't cut. Open the jaw and try to catch the half. Now it is half cutting because this will cut distal to proximal and then cut it. And it is cut. And see here, only half of the lumen is cut. So in some time, suppose this is a fallopian tube and here is a Thalapring applied. And you have to do recanalization. Either side or hulka clip or filsi clip. Recanalization. Then you should use hook scissor. You will go cut this side, again you go and cut other side. And in between whatever was removed, and either side you have a very sharp cut margin. If you go with the other scissors, it will give you hesitated cut. And there will be a lot of injury to the major salpinx also. But here, because it is cutting distal to proximal, so there will be sharp cut and margins will be fresh. And then you can do the recanalization. So this is a very useful scissors. Not only that, even to do cholangiogram or to cut the proline sutures after suturing, this can be used. So this is hook scissors. Now other scissors you can just transfer it. You can give them. Other scissors which you can use is the straight scissors. This is straight. Straight scissors are, take care that the eye of the other people. Straight scissors, they are not curved, it cut straight. Like suppose you want to do CBD exploration. You don't want the curved margins, you want a straight margin. Or if you want to cut the serous layer of myoma. Or if you want to cut the hernia in the peritoneum, you can use straight scissors. Now this is called as micro scissors. This is micro scissors. Micro scissors are very small scissors. These are used for fimbrioplasty or sometimes direct bowel adhesion or tubo-ovarian mass. Just like yesterday you might have seen that the bowel was directly adhered to the anterior abdominal wall. In those situations, at that time I have used curved scissors, but ideally it should be micro scissors. Because micro scissor is so fine and delicate that it cuts small pieces and it will only damage the serosa. But if you will use a big blunt curved scissor, sometimes it can perforate. And sometimes the fimbrial and other tube, we have to cut. Suppose there is distal tubal obstruction and you want to do fimbrioplasty, you will use the micro scissors. Remember, there are two structures in the body where electrosurgical dissection and blood dissection is not recommended. One is bowel, other is tube. If elsewhere you can use blunt dissection like momentum, you can use energy, coagulate with the bipolar and cut it, no problem. If there is a bladder, you can use blunt dissection with the platelet, peanut. There is one instrument that is peanut. Can you see that? That is platelet. Platelet is a beautiful instrument in laparoscopy. This is peanut. Peanut, just like how the small sponge we are holding in open surgery. This is also, see, this is peanut. If you want to separate, you can separate like that. And it is completely atraumatic. And it is separating. See, this is platelet. Platelet. It is basically simple a cotton piece which with the glue they have put it so nicely that it acts as a blunt separation. for separating the bladder or for separating the some of the gallbladder or separating the gallbladder from the body of the liver or fundoplication or budge suspension, sacropulpopexy. Everywhere blunt dissection you can do.
This can be reused, sir, or disposable?
Actually disposable because it is a cotton, so once it become with the body tissue weave, then it is not expensive, it is 500 rupees only, and this is just hold like a pencil. It will hold very easily, it will go inside, and this will you will do like a pencil.
So manually you do.
Yes, manually you have to do to separate the bladder or omentum or whatever. PLEDGET. D is silent, place it. So this is one blunt dissection you can use. But sometime what happens, if the bowel or tube is there, no blunt dissection works. Or tube, if bowel or tube is directly adhered with any tissue, then remember always the adhesive scar tissue is stronger than the serosa of the bowel. Scar tissue is always stronger than the serosa of the bowel. So if you try to do the blunt dissection, scar tissue doesn't break. What break is your bowel or tube. So that's why we are using sharp dissection. Purposefully we are cutting, so that we try to remain more towards the abdominal wall or more towards the uterus or whatever place it is adhered, and then sharply we cut. It has two advantages. One advantage, you can cut the scar tissue directly. Another advantage, in cases of rupture also, perforation also, margins will be sharp cut, so the suturing will be easy. It will not be a lacerated cut. So in those situations, micro scissors are very good. Energy also you cannot use for additional lysis in bowel because there will be collateral damage. And energy at that time looks only white scarred, but after 2 days it slough out and perforate because it goes more deeper, and then peritonitis after 2 days happens. But if you do use the sharp dissection,
With micro scissors.
micro scissors. Only micro scissors. Why micro scissors? It will cut one small in one, and then plane will be created. And that's why in those situations this is not only, sometimes if you don't have you can use other, but it is more preferred. So this was regarding the scissors. So you have different type of scissors. Curved scissor is mostly used for simple artery and vein. Advantage of having the curved nature is just by rotating tip can be visible. So if you have to cut the cystic artery, you make a window and then you go and it will rotate, so the tip will be visible and then cut. So that accidentally you cannot bite the structure behind. That's why it is curved. So these are, yes?
Micro scissors, only one jaw moves.
Most of the micro scissors are single action jaw, so that you can make a plane better. Although some are double action also. Now, next instrument which I am going to demonstrate to you is the clip applicator. Titanium clip applicator. There are two metal in laparoscopy which is very safe. One is titanium and other is nitinol. Titanium and nitinol. Nitinol, N-I-T-I-N-O-L. Nitinol and titanium. These are the two which is inert. It doesn't react with the human body. Titanium is used in the clips. Nitinol is used in the staplers. Endogeal linear staplers. All those staples are made up of nitinol. Nitinol is used for long time by cardiac surgeon to do the bypass. They are using nitinol to take the internal memory artery and to do the bypass. They use nitinol. They don't use absorbable suture or the simple suture without metal. Nitinol is used so that it will not get infected and it will be more secure. So these nitinol and titanium, they don't react with the human body. Now this is a clip applicator and these are the titanium clips. It has three sides. One is small, another is medium large and another is large. A small one comes in the blue cartridge, which is not there right now. This is medium large. That comes in the green cartridge. And this is large, which comes in the yellow cartridge. You know, the blue one is used for the securing the vessel up to 3 millimeter. And that's why people they don't use it. Because 3 millimeter vessel anyway can be coagulated also with the bipolar and monopolar. So generally 3 millimeter nobody is interested to clip. But electrosurgery cannot coagulate the vessel more than 3 mm securely, confidently. Electrosurgery only can secure the vessel up to 3 mm. Harmonic can secure the vessel up to 5 mm. And ligation can secure up to 7 mm with the confidence. So if you have a simple monopolar and bipolar, then up to 3 millimeter you can cook without using any clip. That's why blue cartridge is generally not used. But sometimes cystic artery or uterine artery or some other vessels, in those situations you have to use green cartridge. That is, green cartridge can use up to 6 millimeter of the structure you can secure. And the yellow can be used up to 8 mm of the structure. Like if you want to do renal artery, splenic artery, in those situations, or very much dilated cystic duct, in those situations you have to use yellow cartridge. And green is used in the simple cases, like simple cholecystectomy, or suppose appendicular artery or ovarian artery started bleeding, then you will use green one. And the yellow one you can use for this purpose. So these are the two cartridges generally used. Now this is clip applicator. You know, according to the cartridge, the company will give you the jaws, different jaws. They will give you only 3 jaws. These are the jaws. And you can remove it and you can attach another one. It is just you will rotate, yes, and you can open it and you can attach it. Now, you should hold the clip applicator not by here. You should not hold there. You should hold by the shaft. And then keep the cartridge in front and then you will press it. As soon as you will press it here like that, it is loaded. It is loaded. It is loaded. Here there are clips are there, which is loaded here. This is loaded. And once it is loaded, then you can clip it. So you will go with the jaw and put it press. And keep it pressed for 3 to 5 seconds. And then open. Now it is clipped. And there is dumbbell formation. If you see very carefully, there is constriction in between. Isn't it? And swelling either side. And now it will not bleed. You have to apply 3. 2 proximal, 1 distal. Even in cystic duct, you need to apply 3. 2 towards the CBD and 1 towards the gallbladder and cut in between. So this is beautiful in clip, and it was one of the first type of hemostasis which was started in laparoscopy, and that's why laparoscopic cholecystectomy became very popular. Because at that time people were not knowing how to do suturing and knotting and all, but clipping is very easy, go and clip it. Titanium clip, once upon a time it was thought that it is very good. It is good and it doesn't have any complication, but recently few complication has been reported. One of the big problem of this titanium clip is that MRI is not possible just post-operatively because it is metal. And sometimes suppose you have accidentally clipped at wrong place, or if you have applied it and if immediate MRI is required, it will get dislodged. Second problem is that long term few cases of the cat eye stone has been reported. That is also called as cystic duct clip stone. What happens sometimes that ideally when you apply the clip should be projected either side. And if you hear it is projecting either side. But sometimes our clips are small and cystic duct is dilated and you don't have the large clip. So what we do, suppose this is a cystic duct, anyhow you are trying to excuse it and try to accommodate it. Or some people, they do a step ladder. What is a step ladder? They apply clip and cut. And once it is cut, scissor head, bubble. So they apply one clip and then they cut it half. Then apply another. And then again cut. This is called a step ladder technique. And then apply a third. And then they cut finally. So 1, 2 and 3 clips were there. Now the clip which is inside, in the middle, that is not exposing, that is not projecting outside. So it will get internalized into the lumen. The body will pull it into the cystic duct. And it will act as a nidus for the bile salt and bile pigment to become deposited there. And Professor Bursey has reported it first, that he performed one cholecystectomy, and after 1 year, patient came with the jaundice. So he did open choledocolithotomy. Just by curiosity, he tried to cut the stone, and inside he saw that there was shiny, glistening titanium clip-like was visible. So it was looking like a pupilla, and because titanium clip was having the yellow deposit of the bile salt and bile pigment, so it was looking like a pupil of a cat. If you see the pupil of a cat in the dark, they have horizontal yellow slit like pupil. They don't have pupil like ours, the round. So he has given the name cat eye stone. Or in some book they are writing cystic duct clip stone. So these are the problem with the titanium. Another problem is that if you are applying titanium clip, the distance must be very accurate. The distance between first and second clip should be 3 mm, and distance between the second and third clip should be 6 mm. So why? If it is less than 3 mm, then what is the problem? The problem is that second clip will make first also loose. I will show you. You know, clips are holding in the place because of dumbbell formation. What is dumbbell? Dumbbell means constriction in between. This is dumbbell. And swelling either side. Isn't it? So this dumbbell will not allow it to slip out because it is this swelling both the side doesn't allow it to slip. Even in the knot, even if you are tying a knot on the artery, same way it works. But here this is dumbbell. But I will show you, if he will apply the second clip very near to the first, like here. This is one clip, and he will apply the another very nearer to the first, like here. Press it. See here. Now open. I will show you both is out. Both he was loose. Both is slipped. I have taken both out. Both was dropped here. So why it happens? Because dumbbell of the first is nullified by the dumbbell of second. You got it? Because this is here and other is very nearer. So it becomes, both becomes loose. So never bring the second clip less than 3 mm nearer to the first one. Sometime in the short cystic duct, we applied one clip and there is no much space, so you apply one over another, thinking that I am at least making the first one more strong. But you are actually making the first also loose. So if you don't have a big distance of cystic duct, be happy with the one clip only and then cut after 3 mm. If you are applying very nearer one to the another, both is loose.
System should remain more than 3 mm.
3 mm distance should be in between the first and second clip. Now the question is, why it should be only 6 mm away between second and third? To cut in between, but why not it is 2 cm?
Otherwise the clip will slip.
Yes, 3 mm. No, you are correct. First and second is 3 mm. But second and third,
The 6 mm.
3 each. But if suppose I will make a, in between second and third, if I will make 1 cm.
The clip will slip.
No. Then why
Length
clip will slip?
The length between the two jaws is approximately 6 millimeters.
No, what I am showing, this is 3. This is one clip. Second is 3 millimeter away. But third, if I will apply this here, long stump, if I will apply long stump, then what is the problem?
You will have a blind loop.
Yes, this blind loop, and this clip will get dislodged. You know what happened, I will tell you. Suppose this is one clip, 3 millimeter. And in between one and second clip, I will leave 9 millimeter tissue. Then it will be blind loop, means necrosed tissue. Because there is ischemia in between. If the distance is only 3 millimeter, both the clip will be fibrous together. And if distance is more than 6 millimeter, suppose 9, 12 millimeter, then it cannot fibrose. Just like simple example, if I will tie my finger here with a tight knot, it will become gangrene. And after a week it will slough out. But if I will tie my finger at the tip, only leaving 3 to 5 mm, that also will be gangrene, but it will not be slough out, it will be phagocytized. It will be mummified and pulled inside the body. So our body has a capacity to fibrose the tissue up to 5 millimeter only. If the dead tissue is 1 centimeter, 2 centimeter, it is not going to pull all. It will slough out. And then clips will start migrating into the abdominal cavity. There are many cases reported where clip has created big problem. Remember, titanium clip ideally should be not lost inside the abdomen. If it is dropped accidentally, we should try to remove it. If you will not remove, 99% time nothing happens. It will drop somewhere on the peritoneum and it will be covered by the fibrous tissue. But rarely, sometimes very bad complication happens. If you will put in the Google the titanium clip complication, hundreds of articles, hundreds of case reports are published. Few examples I will give you. One hernia surgeon, during the laparoscopic inguinal hernia, during separating the sac, he has encountered some bleeding, applied 4, 5, 6 clips, and after 1 week, patient came back palpating all the clips in the scrotum. That what is this? It has migrated into the defect and goes into the there. Because in laparoscopic hernia repair, you are not doing herniorrhaphy, isn't it? You are just taking the sac out, and the defect is already there. You are just covering it with the mesh. So defect was already there, and with the little seroma, all these clips were inside the scrotum. So later, the patient has to, under C-arm guided, they have to give incision and pick up the clips out. Another case, one 14-year-old girl who was working as a gymnastic in the circus. She was having the cholecystectomy done, and after 1 year she has a severe backache. And once the MRI was done, one clip has penetrated retroperitoneum and pressing one of the nerve. And then the neurosurgeon has to remove that clip out. So clips are, because whole life it will be there. It is not going to absorb because titanium is a metal. So if accidentally it goes to wrong place, then it can be painful or it can create some problems. So don't make a distance between first and second clip more than 3 millimeter. Otherwise it may be lost somewhere. So this was regarding titanium clip. Now, is there any alternative of titanium clip? If there is so many problems, then yes, there is one, Hemolock. Hemolock you can use. That I will show you. This is Hemolock, and here, this is 3 millimeter clip applicator, titanium clip, but that generally it is not used. So now this is Hemolock. Hemolock also, the different color coding, different cartridges are there which you can use it. It is expensive.
Question, what is the maximum vessel you can clip with a medium?
8 mm.
Medium clip?
No, medium large 6 millimeter. And ideally, because if you will apply 6 millimeter, then little bit 1 millimeter either side will be projected, isn't it? Some people even the dilated cystic duct anyhow they want to squeeze it out and to apply it. Or one apply this side, another apply that side. They are applying one from this side. Why they don't have large size? So that way you can try to adjust, but ideally more than 6 mm with the medium green cartridge should not be used. You should, if it is more than that, you should use large one. That is yellow cartridge.
Size of a clip not depend upon the age of the patient.
It
Depend on the size of the
structure which you are applying. Age of the patient, why age will affect?
Size of the structure.
Yes, that is always there. A small child, diameter of the cystic duct will be less, but diameter of the structure is important. Diameter, even in the adult also, cystic duct diameter varies depending upon the pathology. Suppose some stone is already there in the cystic duct, then even the large size will not fit. And only option what you have is knotting. That is extracorporeal knot, which we will learn. Sometime you have Mishra syndrome or you have partial cholecystectomy. So you have to do in-mass ligation at the level of the neck of the gallbladder. In those situations, clips are useless. You have to use knot. And what are the knot? That we will learn. So it is diameter of the structure is important. Of course, age is also. What age is doing? It is changing the diameter. So of course, if the child is very small, then even the blue cartridge also you may require.
when we can do MRI for the patient after how
MRI after 6 weeks you can perform. Although yes, but sometime if it is recommended already injury is there, then we don't care about the slipping of the clip. We do it immediately post-operatively. Now these problems are not there with the hemolog because it is made up of silicone. And some absorbable clips are also there. Now here this is the clip, this is the hemolog. Same way you will put it like that, and this is the clip applicator. You will bring it and press it like this. And here it is loaded. Can you see that? This is loaded. It is beautiful thing. It has like that. So it will get unlocked like this, just like the hair clip.
yes.
When you put the hair clip, it gets locked same way. So this is completely encircling all around. Pardon? Most of the clip applicators are 10 mm. Even the titanium 10 mm clip port is required. You cannot use with the 5 mm. With the 5 mm only you can use 3 mm. And 3 mm nobody is using. Isn't it? So most of the clip applicators are even titanium or hemolog is 10 mm. There is no 5 mm clip applicator.
It looks like it's better than 10 mm.
No, it is not. I will show you. Now at camera though. It will go in camera. It is not. So this is looking, but it is 10 mm. So can I have this? Disposable camera de do koi uधर से. Okay? You can just by the time you can transfer it. देखें लॉक बायोडिग्रेडेबल मीन्स वो अगर आप प्रेस करेंगे ना तो वो लॉक हो जाएगा. Once you will press it, लॉक हो जाएगा. अब फिर खुलेगा नहीं तब. Now it is locked. Now it will not open. Maybe with the artery forceps purposefully if you will open, then it will open.
Sir, all the three types can be taken with a single clip applicator.
Yes.
No, not about this.
Yes, that also. Can I have this? Just you will see, all these are 10 mm here. You have to little partially, and here it goes, right? So all are 10 mm. So, what you were asking?
There are three types.
Jaws are changeable.
Oh.
So you can.
So if
change.
you are planning to take that yellow one, you should use the yellow, suitable for the yellow.
Yes. So the cartridge. Oh, yes. Ideally, the jaw which lock should be up. Yes. This way.
This is the show.
Yes. Yes. So here, can you see this groove?
Yes.
This should be up. So No, उसका skip.
Can you place about 10 mm, so you need to close the jaw slightly?
No, in titanium you don't need.
No,
In silicon, little. At the time of introduction, little. Yes, at the time of introduction, just at this level, little. After that, no.
If you enter inside, it's already closed.
Yes, because if it is half pressed also, it is compressible. You know, Hemolock has one good thing that it is like a spring action, but titanium it is not a spring action. If you will press it half, it will drop. So that's why in titanium one, during introduction, you are not supposed to hold this one, because accidentally if it is pressed, it is loose. I will show you. So titanium clip applicator also. No. No worries. Why? Because it is elastic.
After applying that,
Yes. Once it is locked, then only it will not open. Otherwise, here this is titanium one, and if you have applied it, and suppose accidentally in the halfway you will do like that, then it will drop. Because it is metal, isn't it? In metal, if it is half pressed, it is loose on the jaw. But this is elastic because it is made up of silicon. So it is compressible, but still tension is there. So Hemolock is more preferred, but only problem is the cost. इसका tip दिखा, tip see, tip can be opened from here. You were asking about the jaw. This is medium large. Can you see that? Large size. And here you can open it.
So the other way of clip nomenclature is 200, 300, 400, something like that.
That is the same. LT300, LT400, LT300 is medium large. But that is a brand name, trade name. Trade name. Because LT300 is for Ethicon. Isn't it? But same thing if you buy from Starch, it will not, they will not give you LT. There is model number. LT300 is medium large. LT400 is large. And LT200 is small. So this is out, and this jaw was medium large. If I were to change large one,
It was written there, sir. It is
no, it is not written.
just by experience.
Seeing the size, you can adjust it. Unfortunately, they are not writing. And this is large one. If you want to take a smaller jaw, here is the smaller. Smaller is seldom used. It is not used. So mainly medium, large, and large.
So the company providing
Yes.
the clip
This is
applicator,
for falloping application. Yes.
the company providing the clip applicator will provide all type of jaws.
All the three they provide. You know, generally I will tell you, most of the time, Starch is not selling the changeable jaw. They give you all the three separate.
What about striker?
Why they don't change it? Because there is no benefit out of that. Otherwise you will buy three clip applicators. And one excuse what they are giving, that sometime if the jaws are changeable, they can drop into the abdomen. So they make it complete one piece, so that it will not be dropped. So technically they are correct. Because I will show you sometime during cholecystectomy the video that it drops couple of times.
The striker,
Especially if nurse has not kept it. Other one more problem is there. I will tell you. Lot of people applicated. If suppose your nurse doesn't like you, then what she will do? Suppose this is a tip applicated. 2 times she will make it loose. And now, even if you will press it fully, jaw will be little open. Isn't it? So your clip will never be. Yes. So always take care that before loading, make it sure that it is fully tight. And now if you press it, there is no gap. Isn't it? So these problems, why it is happening? Because it is replaceable. If it is not replaceable, then this problem will not happen. So that's why Starch is making all the sizes of clip applicators separately. They don't make it in one. So now this is fallop ring applicator.
Is there a problem if you use a large clip on a vessel less than 6 millimeters?
Not a very big problem, but yes, sometimes what happens that a lot of tip margins projecting here and there, sometimes with your drain or with the other thing it can entangle. Unnecessarily applying very large size clip for very small diameter structure is also not very good.
I was just asking because sometimes you might end up with a big clip, but with a smaller vessel and you're kind of stuck. So
No, then you can apply. Then there is no. It is not a very big problem. You can apply. Because once the clip is nicely pressed, it never leave any even a fraction of millimeter space in between. So even the small diameter structures can be easily applied for large size clip. If you don't have. But generally that much a small structure can be cooked also.
So prophylactically, we should use the 8 mm clip always while doing cholecystectomy.
Why?
So mainly because it will clip the CBD properly. Sorry, the cystic duct properly.
This is the problem which you are saying. Do you know if you have to apply large size of clip for any structure, you think it twice, it may be CBD. You got it? Any structure which is not fitting on the medium large may have the tended CBD. So if any time if you are asking for large size, think twice. That is really you are applying over cystic duct or it is tended CBD. Isn't it? So generally large size should be avoided. Because medium large size will not accommodate over the CBD. So this is safe. If medium large size is the structure you are applying and already it is projecting, then it could not be CBD. Normal CBD diameter is how much? Approximately 6 to 10, it varies, 6, 7, 8. So that's why the company has taken this precaution that they make the size in such a way that it should not be applied to the wrong structure. Right?
Yes. There are 3 varieties of sizes, the
Yes, hemlock also, you have the blue, green, different colors are there.
Sleeve applicators are 2 types.
Suturing and knotting is the best method of tissue approximation. Whenever you can prefer, always suturing should be used. So how to ligate the cystic duct by suturing, I will demonstrate you in the lab and in the OT also. We will demonstrate you. Suturing knotting is the best method of tissue approximation.
Muscular than.
But yes, but mostly done by the clips because it is easy and it is time saving and it doesn't need practice. Yes.
So, clip applicators are 2 types. One, those are reloadable. After every fire, you have to load them. And the second is multi fires, which can you can keep on firing 1, 2.
Yes, that I will demonstrate you with the disposable instrument.
Do we have any third variety which is reloadable but multi loads can be done?
No, why? Because if you will, these are the multi-loaded. Here already it is loaded, and then you will keep on firing, and it has 20 titanium. If you see here, this is 20 titanium. It is written.
What is the cost, sir?
And with every firing, it will come.
It's
So lab keep this away. I will show you. If you will buy separately, it will cost you 12,000 rupees for one, and it has 20. But actually, ideally, even if you have used 2 of this, you have to throw it because the blood and the tissue already infected, isn't it? So yes, difficult to clean because it is already loaded inside, and if the tissue and fluid is there, then it is infected. Although if you can put directly everything into Cytex and you can use it, but ideally it should not be used. So,
size also?
pardon?
This size also, or?
This is also coming with the 3 sizes, but generally most of the time medium large they sell. So I will show you. It comes in the Laparoscopic kit here. This is a Laparoscopic kit which I was talking about that day. If you will open it, then it is already autoclaved. Already autoclaved, what means gamma ray sterilized. And inside just you have to transfer it to the instrument trolley. And inside it will have 3 tires. In the first, you have to open it from here like this. It is open, and here in the first layer you will have one reducer. This is universal reducer. There will be 2 10 mm and they will give you only one trocar for 2 cannula, isn't it? Because one trocar at one time you will push, so you will charge it and it will go. Here is a blade. Can you see the blade? This is bladed trocar and very sharp, new. And once it will go, then take it out and put in the another one. So they will give you 2 cannula but only one trocar. Exactly 2 10 mm, 2 5 mm. There will be one varus needle. This is one varus needle. Disposable varus needle has a ball there. This red color. Do you know this is safety? Because accidentally if you go in the vessel, this ball will come up and it will further, because they don't have valve. Unlike to the, but sometime if you want to attach with the valve, they will give you a separate lever lock which you can attach it like that. Isn't it? And then you have the valve also. And you can attach the gas here. So they give you, and this is the first. Now in the second layer, you will have one seizure, one grasper, one Maryland. These all are disposable. Disposable instrument has a beauty that weight is not more than 50 grams. And it's very convenient. How to hold? Thumb should go in the back hole. This finger, 2 finger will be here. Index finger is to rotate. Remember, in any laparoscopic instrument, either it is disposable or reusable, you should try to open the tip jaw instrument only when the jaws are open. You should not rotate it when the jaws are closed. It will not rotate also. See, if you close the jaw and then try to rotate it, it will not. It will not rotate. Try to close it tight and then rotate. It will not rotate. Isn't it? कस के प्रेस कीजिए. अब rotate कीजिए. It will be hard also. And if you rotate anyhow, it will break. Inside there is one washer which will break. So always open it, and this is for. So you have the seizures, you have the Maryland, you have the grasper. In the now third layer. This is the second layer. After second layer, you have third layer. In third layer, this is the clip applicator. So it is already loaded. Can you see one clip is already at the tip? Yes. So let's now. So I will show you. So tubing. Suppose this is just hold it and apply it. As soon as you will apply, press it. See, another is already again loaded. So you keep on firing, but remember, you might be firing a lot wrong places also, because it will not take your time to think about, and you are keep on firing. 20s are there already. After 20, there is no. So there is no in between actually. Either single use or already preloaded disposable. But again, even if you have used one, you have to throw it actually. So, and the cost of entire this is 75,000 rupees. Pardon? This one may be, let me see. No, cartridge is there. This is scissors. This is scissors. Cartridge is always there here. You can attach cartridge in every instrument. If you don't want cartridge, you can attach it or keep it attached. Although it is single use only. Only one time. Pardon? Curve. Yes, only curve scissors they will give you. But you know, in spite of these all, you may have to use your own reusable instrument sometime. Because you may, but most of the time, one cholecystectomy, this kit is sufficient. You will be able to do it.
They provide 2 cannula only. This means they do once only?
No, 2 10 mm, 2 5 mm. 4 cannulas are there. Standard, according to the American College of Surgeon guideline, standard laparoscopic cholecystectomy should be done by 4 ports. If you are minimizing, it is, but standard technique is 4 ports only. If you are minimizing, you can do single incision also, you can do the robotic also, you can do notes also. But generally 4 ports are good.
So this Ethicon is having multi-loaded devices. Ethicon.
This is Ethicon only.
This is Ethicon.
This is Ethicon only. Covidian also they have. Covidian also they are selling. Ethicon and Covidian, as I told you, these two companies are giant manufacturer of the disposable in the world. Now this is simple.
Excuse me, sir.
Yes.
For ectopic and triple ligation, do you advise us to use clip?
No. This is a good question. But remember, that's why I am telling you tube ligation this one. Do you know any metal should not be used for tube ligation because titanium is a metal. So in due course of the time it get internalized, and on the top of that it may get recanalized, and after that it may act as a needles for ectopic pregnancy, isn't it? Because it is metal, and metal is crushing. So in those situations it should be used only for the end arteries or for the end duct. It should not be used for ureter, or yes, ureter you can use if you are doing nephrectomy, but you should not use for tube. The titanium clip is absolutely contraindicated for tubal sterilization. For that, here this is a fallop ring applicator. There are two types of sterilization. One is destructive, other is occlusive. If you want destructive, then don't do anything, apply bipolar and cut it, just like yesterday what we did. You don't need destructive. But only drawback of destructive is any time recanalization is not possible. Do you know sometime what happened? For the future IVF, if we do the destructive and suppose IVF is failed, then patient sometime come back, they will now open my tube. In those situations you will be in big trouble. But if you have used the fallop ring or facing clip, you can do the recanalization is more successful. So destructive is used only for the patient whose family is complete. Destructive, you can use Pomeroy technique also. You can make a rudder's loop laparoscopically, and you can pull the loop and you can tie the knot. Or you can use the bipolar, monopolar or thermocoagulation. Occlusive is of three types of sterilization. One is fallop ring, other is filcy clip, and third is hulka clip. Fallop ring, this is fallop ring applicator. Fallop ring applicator has three parts. This is called as ring applicator. Let me show you a little bit picture also, so that it will be easy for you to see. Okay. So this is physically. This is fallop ring. And I don't know, this Sony is getting a big problem. It doesn't go. This automatically go to the other side within few seconds. And here you will see it is a hulka clip. Hulka clip is just like a titanium clip, but it is not metal, isn't it? This is fallop ring is just like the hair band. So loop. If you are, yes, or piles band, piles rubber band. Facing clip is just like hair clip, which is just like the hemlock here, isn't it? So there is a notch and sachet. And hulka clip, which you will see here, this hulka clip is just like the hairpin. Hairpin, when you are pushing in there, it is already pressed, but it is made up of silicone. So these are the three methods of occlusive method of sterilization. Now this is called as fallop ring applicator. This is called as ring pusher. This is called as ring cone, and this is called as ring. So what you have to do? First you put the ring cone over the fallop ring applicator, and after that put the ring over the cone, and then you will push it by the pusher. And over the applicator there is a ring delivery selection collar. It is written here 1 and other side is written 2. So if this knob is parallel to this handle, then only distal ring will be discharged. And if this knob is at right angle, then the distal and then the proximal will be fired, discharged. Principle is very simple. Now you can see this side. It is just like the Piles band applicator which is used by the surgeons. When the female has to put the hair band in their hair, what they are doing? First they are loading the hair band in the hair like that. Isn't it? Then you go pull the hair and fire this band over the hair. Exactly same way, this is the Fallop ring applicator and this is the ring cone. So put the ring cone over the Fallop ring applicator like this. After that take the ring, the Fallop ring, and put the Fallop ring over the cone. And this is a ring pusher. Don't use artery forceps. Some people what they do, how they do, I will show you. This is artery forceps. They put the Fallop ring over the artery forceps like that, and then they open the jaw of the artery forceps, and then they load it this way. It is loaded. Can you see that? But it is not a good technique. Why? Elasticity will be lost. It is recommended by the company who make it that even if you have loaded it more than 10 minutes, you should not leave it. Otherwise, elasticity is lost. You should apply it immediately. So I am applying two here. So this is cone. So ideally, how to do? You use the ring pusher, and here ring will be pushed. Pushing, and as soon as it will, then it will automatically take the cone out. Now the cone is out, and now it is ring is there, isn't it? 2 rings are there. Now here you have the ring selection delivery collar, and you can rotate it 1 or 2, 1 or 2. Suppose I want to fire both together, then I will put to the 2. And then suppose this is a Fallop ring. Now open it. You go first inside, and after going, suppose this is uterus. This is uterus and this is tube. Then what you should do? You should go behind the uterus and hang the tube up like this. Because you have only 2 instruments. One is telescope, one is this. And once you will bring the tube up, how to bring? You cannot catch it. So idea is go behind the uterus and then come lateral. Just like when you are catching the small kid, then you go and you hook it to the arm. Isn't it? Same way you go and hook the Fallop ring. And now open the jaw. Open. Put the finger, put the, and open it like a syringe. No. Yes, open. No. Yes. Open. And now jaws are out. And then you go and hang it. Hang it. And now slowly press. But remember, when you are pressing, you should advance it also towards the tube. So that tube should not be pulled towards you. You should not bring the tube towards you. You should go towards the tube. Otherwise, it will get detached from the major sharpings and bleeds. So now go very good and close, go, and fire, done. Now open the jaw and it is done. See, it is applied. Here it is applied. So it's a very simple mechanism and very easy to apply. In this way, how to do? I will just show you the video. You have to apply 2 centimeters away from the uterus. That is isthmus part. Why isthmus part is preferred? Because it is thinnest part. If you apply on the ampulla, it will bleed, it will cut through, or it may be partially applied. Isn't it? Partial. Another recanalization is more successful in this area.
Can be pregnant again.
Yes. So now this is uterus, and how to locate the tube? You have to hang it like that. Better to go behind the uterus by the Fallop ring applicator and then come lateral, and it is up. like this. You don't need uterine manipulator for this small procedure. And now take the jaw out.
We need to do window in the middle.
No, window is not required. No window. No window. Window is not required. Window will bleed, and here you go and hang it. And then slowly, while you are closing the jaw, you should advance. Slowly move towards the tube. And here it is. And it will be pulled into the Fallop ring applicator, and the ring will be discharged over the tube. And slowly, you should not give a thrust, otherwise it may cut through. You don't fire like a pistol, slowly you do it. Just like how you are giving injection slowly to the patient. And here it is done. And now just open the jaw and it is over. Is it done? Open the jaw and it is disengaged. And here it is done. So it is important, see here, that entire loop should come. Isn't it? If you will apply here in the ampulla, only that much will come. It will not be a full thickness, full lumen. And in those situations, there may be chance of recanalization or failure. So, this is the simple instrument that is called as Fallop ring applicator. Now, remember, that is not a actually Fallop ring. This is a rubber ring. Fallop ring is white in color. This is white in color.
Usually again the bushes.
First.
First,
Like this.
No, first it will be closed
Yeah, like
with the ring loaded to move the tube up.
okay.
Because it should be blunt. And after that, open and then hang it, and then fully fire now. Yes. So that there are actually, it is very simple, there are two tubes. One tube is inner, other tube is outer. And the ring is loaded on the inner tube. And outer tube is pushing it out. See here. When you will press it fully, outer is pushing the inner. Isn't it? So there is no way ring has to jump.
But to open the flanks, we should push.
Yes, for open the flanks, you
But
go
first I do this, then I touch the
hang
tube.
it and then press it and then fully press it. So, this is a Fallop ring, you can just give it to see. Yes, it is very cheap in India, it is only 10 rupees cost for Fallop ring. Yes. Right angle artificial. Right angle variant, no?
No, this one.
Okay, that is ring selection delivery collar. I will show you. What he is saying, see here, what is the principle here? Which is also very simple. If there is one knob, can you see this knob? If this knob is parallel to the handle, then this tube will only go half. It cannot, inner tube cannot go fully in.
One rubber.
So only one rubber will be fired. And if you will put it at right angle, then it will go fully in. So both will be fired. Got it?
I
So
did
here-
for 2 rings.
No, one is
One
sufficient. One. But some people they want to load both of it at one time, and one side they fire one and then rotate, other side fire another. Some people they are so afraid. In India the law is very bad. If you do a sterilization and if it is failed, then up to 18 years of the age of that baby, doctor has to pay for their education, for their all
Take his
the
name.
maintenance. Yes.
Take his name also.
But you have to pay for them. So they generally afraid. So they apply two either side. But remember, if you are applying two, then it is better to do destructive method of sterilization. Apply bipolar at two places and cut at two places and take a small piece of tube out for pathology. So they do it. But
in very thin patients, the tube is very small. Very small. If you put the tip over the isthmus, it will just slip off. In those cases, we will put two clips, the two rings.
That's a wire.
One side and two rings on the other side.
yes, if you want, you can do that. But I don't think that the thickness of the patient is always related to the tube.
No, sir.
Sometimes even in the very thin patient, there may be very big tube, isn't it? Or vice versa. And if the patient is approaching menopause, then even in the very obese patient, the tube will be thin, uterus will be atrophic. But of course you are correct. But one major factor is the quality of your ring also. If you have spent a lot of, expiry is also important. Sometimes it is expiry is only 1 year. Sometimes it is old fallopian ring and then it has lost the elasticity. In those situations you are correct that it may get slip out. So if you apply 2, you are double sure. But what I am telling that then why not to do the destructive?
In laparoscopic procedures in India,
yes, you are correct.
They will give only 2.
2, yes, of course. You may not have the energy sources. You may not have bipolar.
Yes.
Of course, you are correct. And one more thing is that most of the time they do by single puncture. Single puncture, and even the CO2 is not used. With the ambu bag, they put some air. So the time is only 2-3 minutes time you have to finish it. So absolutely you are correct that it is better to apply 2 places so that you can sleep well at night, that everything is fine. So now I will demonstrate you some of the. This is rubber ring. Yes, it will do the. No, it will not disappear. It will remain. It will not disappear. Throughout the, I will show you how it will look like later. Later, even after 5 years, if you will see, or 10 years also, you will see. See here. Can you see this? This is the previous applied fallopian. This is recanalization. So you have to inject the vasopressin over the mesosalpinx, and then with the hook scissor you will cut it, and then you will do recanalization. So how to do recanalization, that I will discuss later. End-to-end recanalization. Only 4 stitches are required. One at mesosalpinx, after that 6 o'clock, 10 o'clock and 2 o'clock. So one is 6 o'clock out to in and in to out. If you leave the mucosa, submucosa, it is good. Pseudomuscular. 6-0 or 8-0, Vicryl or Proline, both the people are using. So you can take out to in to out 6 o'clock. But before that, mesosalpinx should be, and then 10 o'clock, and then 1-2 o'clock. So this way you can do the recanalization. Here it is going out and suture, and it is in. This is 6 o'clock, then you will take 10 o'clock, and then 2 o'clock. And now you will do that.
Out in? Just.
Pardon? Out to in means if right side, if proximal you are going out to in, distally in to out. Single layer means the question is continuity single layer, interrupted. And then you will inject the methylene blue, and here the dye is coming. So this is the reversal of sterilization. The videos I will show you later. Now I am going to demonstrate you the different type of uterine manipulator. Uterine manipulators are very important for the gynecologist. It is important for surgeon also. If you are a colorectal surgeon, or rectal prolapse you are doing, and the patient is female, then you have to use uterine manipulator. Sometimes even the hernia in the female, you have to use uterine manipulator. So there are many types of uterine manipulator. One is called as Clement Ferhand. Clement Ferhand is one of the university in Germany. They have invented. Other is Romi uterine manipulator. Other is Indian uterine manipulator. So I will demonstrate you all. Here this is a, if you will do right, it will go retroverted. This is antiverted. And this tip is replaceable. You can replace it, and you have the different size of tips are available.
What's the name?
This is Clement Ferhand uterine manipulator. Suppose patient is nulliparous, you can use very small, that much small. And you have one channel for doing the HSG also if you want. Or you can dye test, you can do. And if the patient has a very big, huge uterus, you can use this one. So the tips are changeable. But this uterine manipulator can only be used for simple procedures like LAVH, or you can use for ovarian cystectomy or tubal surgery. This cone will fix over the cervix, and this will be outside. And either you can keep that way also or this way also. Suppose patient buttock is not up to the age, you can keep that way also. And then you can do anteversion, retroversion, and then contralateral traction just by rotating. But you cannot use total laparoscopic hysterectomy with this because it doesn't have colpotomizer. So up to LAVH, okay. Because LAVH, you are taking just upper two pedicles. The uterosacral, Macan rod, uterine artery, anterior and posterior colpotomy, all is done from below. So in those situations, without colpotomizer, it works. But for TLH, you have to use this uterine manipulator. That is called an Indian version of the Romy uterine manipulator. This uterine manipulator has the advantage that it has a tenaculum also here. This is a tenaculum. And this has a half circle colpotomy. So you can rotate it like that. If you have to do anterior colpotomy, it will be like that. If you have posterior colpotomy, it will be like this. And this is to seal the leak from the vagina once you do colpotomy. And this will be out. You can. Advantage of the tenaculum is that sometime, if the round ligament, broad ligament, all is separated, even though in those situations, uterus become very unstable. It started rotating. So cervix, once it will bite the tenaculum, then it will not rotate and you can maintain the position of so that you can do the uterosacral and proper angles you can cut. There will be no chances of deviating to the lateral. So just like suppose this is a uterus and you will put it, then tenaculum can bite it like this. And now there is no chance here, it is fixed. And it will only if you want it rotates. It will not be unstable, it will not rotate its own. So that's why this is tenaculum. This tip is also changeable. You can change it. And some of these are articulating also. Like you have the articulating tip, you can apply this. Isn't it? According to the size of the uterus. And you can use it different types.
It's Indian.
Pardon?
It's Indian.
Yes, this is Indian.
How you find?
The same is available with the starch also. I will show you that this is the Indian modification. Cost is very less. This one it will cost you 6,000-7,000 only, but the other company it will be expensive. So it is, see here, advantage of being the big is here. Just I will take it here. This is the original starch. If you see, this is the insert. They don't make the tip openable from here. They have entire insert so that accidentally it doesn't break. And it is the half circle colpotomizer, isn't it? And this is the sealing for vagina. And this is the handle. If this handle is 6 o'clock, colpotomizer will be 12 o'clock. If handle you will bring 12 o'clock, colpotomizer will go to 6 o'clock. Advantage of being that much big is that once you introduce, surgeon they themselves can hold it also. So here, see this is surgeon hand. This is the thigh of the patient. Here is you can rest on the thigh, isn't it? And then you can hold it and then you can do the anteversion and contralateral traction. See, uterus is moving. And then you can give it, once you will reach the appropriate traction, then you can give it to your nurse and she will hold it. A good colpotomizer, good uterine manipulator is required. It is essential to perform a nice gynae procedures, because if the person who is doing uterine manipulator is not clever, it will make your life hell, because it will give you a lot of bad position and you will struggle. So how to do this surgery, that we will learn later. During TLH I will explain each and every steps and detail. But again I will show you one more use of how to use the uterine manipulator. Uterine manipulator is very important to learn proper application. Like yes, in this video you will see little bit explanation of the hair. If you are going in down, the buttocks must be of the edge of the table, And then once you are going down, here you can see the entire uterus is moving up. And in those situations, uterosacral ligament will be so tight, it will give you the beautiful anteversion. And here if you move right, inside it will move left. This also is acting as a lever action. And then this is the handle for colpotomizer. And this is the, if you go a little down, it is moving up. And the table is like that. So here, this is the colpotomizer tip. And if you will bring it at 12 o'clock position outside, inside it becomes 6 o'clock here. This is 6 o'clock. And it will give you the safety, you will not damage the rectum. And if you have to separate the bladder, you will bring it at 6 o'clock. And above it will give you the indentation at 12 o'clock. So just push it, and this is 6 o'clock. And now this is bladder. And you see that? And now you can see you can feel the instrument and you can separate it. So a person who is doing uterine manipulator should be a very intelligent person, and he should know the steps of surgery, that at which time, which direction has to be given, how much it has to be pushed. Then only you can achieve. You see the hairs also fallopian ring? Can you see the fallopian ring? Here also fallopian ring was applied once upon a time. So this we will discuss in detail later. So this. Yes, vaginal obturator is there. In this also it is there. I will show you. With many people they use vaginal obturator at the time of closure, isn't it? So I will just show you. And that I will demonstrate you during the entire surgery. Here. Now what happens? Once you will just do the colpotomy, just this is colpotomy going on. Here you see a spatula, and a spatula is cutting this is anterior colpotomy. Here, and this is just the ring. And once the ring will go, it will prevent the gas leak. So before doing the colpotomy, this ring should be in. Otherwise, immediately abdomen will collapse because gas will leak. So this is the ring, and then this is colpotomy. And once the colpotomy is finished, let me take a little forward first. Then you will put the obturator. This is colpotomizer. And over the colpotomizer, you will do the entire colpotomy. This is colpotomy. And now it is almost done. It is done. And now the obturator will be. Now uterus is out. But vault is still open. Isn't it? Now there will be obturator. Uterus is out. And then you will put the obturator. It is like a plug. So that gas will not leak. And over this you can do the suturing. But if you don't have, now this is suturing. An extracorporeal square knot will be used. So how to use, we will learn it. But if you don't have this obturator, then what do? You can easily, so what you can do in those situations, if you don't have, you can take a gloves, put some sponge inside the gloves, and then you can pack it. Yes, gauze inside the gloves, and you can pack. Direct gauze don't put, otherwise it leaks. Because gloves will make it plastic, so it will not leak. So this is a simple Indian type uterine manipulator, which is full circle, and you can push it and directly. Here the only advantage is that even untrained person can hold it. But disadvantage is uterus will remain unstable. And because of full circle in the nature, sometimes admetus cervix doesn't fit. In half, there are two disadvantages of full circle. One disadvantage is it doesn't give you the good indentation, means good bulge. Why? Why full circle doesn't give good bulge? Because suppose there is a uterosacral ligament. Suppose there is a uterosacral ligament like this, and if you are pushing it this way, this uterosacral ligament doesn't allow it to go. But if this is two uterosacral ligament, and if it is half circle, it will go in between two uterosacral ligaments. Am I clear? The full circle, it will say either it will go all together or nobody will go. But half circle can find the way in between the uterosacral ligament or in between the bladder and the pillars. So that's why half circle gives you the better indentation. Indentation means this is indentation, means better bulge. Full circle doesn't give you good bulge because uterosacral holds it. It doesn't allow it to be pushed in the abdomen. But half circle make a space in between uterosacral so that colpotomy is easy with the half circle. And that's why it should be used. Half circle has one more advantage, that even in the cases of edematous cervix or lacerated or amputated cervix, it can make a plane. But here you have to be 2-3 sizes for different sizes of the cervix. This is also a uterine manipulator. This is a very simple uterine manipulator, which is Indian uterine manipulator. And if you will open it, the jaws are closed. So you will put in the cervix and then close it. Because when you are closing, the jaws are opening. Can you see that? And open is closed, close is open. So the idea is that first you introduce into the cervix, cervix will rest here, and then inside the uterine it will open. So now it will not come out accidentally. And then easily you can do anteversion and contralateral traction. The risk of perforation is also there, and moreover it can only be used for LAVH, not TLH. Because in TLH they don't have any colpotomizer. Some people who don't have colpotomizer, they are taking a sponge in the sponge holder forceps and they push it to the posterior fornix so that they can do colpotomy on that. But ideally, if you have a good, the best colpotomizer, best uterine manipulator in the world is original Romi, or there are many, but those are best one are disposable, and those are expensive. Just I will show you some of the best, like here. This one. This one is one of the best uterine manipulator, but only disadvantage is here. It has two balloons. Once it will go in the uterus, you will inflate this balloon, and cervix will go inside. And here you will inflate it to occlude the vaginal orifice. Isn't it? So, and it is very convenient, very good. It doesn't slip also, and this knob is for anteversion contralateral, and then you can do and rotate it. But the problem is it is 35,000 and single use. Because this balloon, once it is deflated, you cannot no more reuse it, ideally.
Complete circle.
A complete circle, full circle. So this is different type, but you know, once you are habituated, like one of my very good friend, Dr. Rakesh Sinha, from Beams, Mumbai, he doesn't use uterine manipulator at all. And sometimes we also don't use, especially in very small uterus, you can use Maya screw. And with the Maya screw. And sometimes in very big uterus also, you have to use Maya screw. I will show you like this, here. In this uterus, there is no role of uterine manipulator. So where you will put uterine manipulator and how much traction it will do. Isn't it? Now in those situations, what you have to do, you have to put a Maya screw. And Maya screw has to be pushed, and then it will pull the uterus inside the abdomen. So in those cases of complicated multiple fibroid, this is Maya screw. And instead of uterine manipulator, Maya screw will do all the job. And it will pull the uterus up. And then you can go with the bipolar. So in those situations, there is no chance of
You need another additional port only just for the
Maya screw. Yes, sometimes 4, 5, 6 ports are also used in this much bad hysterectomy. So this was regarding uterine manipulation. So you want some break? I will give you 5-minute break. Then I will I will start optical part. You know, some of the instruments we have not discussed. Hook, spatula, aspiration needle, knot pushers, needle holder. Why? Because those instruments you will learn during the practice itself. Because once we will start suturing and knotting, then you will learn it.
Needle holders, you want to know
Needle holder.
right angle, the difference.
Okay,
Right
I will
angle,
tell you. The needle holders.
which one to use?
Okay, needle holders are single action jaw instruments. Needle holders should be held by the thumb and index finger. You should not use the hand to hold it. thumb, and this is the way how to hold the needle holder. And these three fingers is to close, index to open. This is close, open, close, open, close, open. You know, you don't press all, otherwise it will break. It will get spoiled also. So this is for opening. This one, and this is for closing. So you press it and open it. Press. When you are pressing, index finger should not be there. And when you are opening, these three fingers should not be there. Index finger is not there at the time of closing. And at the time of opening, these three fingers is not there. So this is closed, this is open. This is closed, this is open. This is closed, this is open. This is closed, this is closed, open, closed. So it should be 3 clicks if you will listen very carefully. 1, 2, 3. When you hold the needle should be, you should hold the needle by the suture, not by the needle. Inside the abdomen, don't play with the needle, play by the sutures only. And drop the needle in such a way that tip should be on the left and tail should be on the right, and press by the upper jaw. Automatically it will get erect up. Even over the bowel you can press it, there is no harm. It will get erect up. And then you will take a bite. This is the curved needle holder. If you see the tip is curved. It is curved like that. Can you see that? It is curved.
There is right curve and left curve?
Yes. But the curved needle holder has only one drawback, that it can be, you have to buy 2. Like curvature should be towards the center. So if I will keep it to the left hand, it is reverse. And I cannot rotate it. Do you know why? Because it is a rule of every single action jaw instrument that moving jaw should be up. If moving jaw is down, you will not see what is moving. If this is down, can you see what is moving? You cannot see. So this is right side here, the needle, you hold it and then lift it and then you will drop it. Here it is dropped like that. You will drop it in such a way, that tip should be left and tail should be right, like this. After that you go with a partially open jaw and press by the upper jaw, and automatically it is erect up. See?
By the upper jaw.
Upper jaw. And then you can take the bite. And then you can suture. How to suture, that we will learn. So this is right-handed needle holder.
Upper jaw is mobile or the lower one?
Upper jaw is mobile. Although if I will put it like that, then the same jaw becomes, but it is wrong. Because you should not hold the handle like this. This is the, you know, one common question sometimes people are asking, why they are not making needle holder this way? Why they are making it straight? Do you know why? Because if you will make it this way and then you take a bite, it will make an arc. But if you will hold it here, then it will swing on the same axis. So that's why it is straight. So it should swing in the same axis. Otherwise, when you will take a bite, it will cut through. Is it clear? So all the needle holder, this axis is very important. And a straight has the advantage. This is a straight one. A straight has the advantage that you can use in left hand or right hand. So you have to buy only one. And another one, if you want, you can use assisting needle holder or you can use simple Maryland. Maryland has only one drawback, that sometimes the wrap gets trapped over the jaw. Isn't it? So that you have to be careful. Or if you pull it, everything cut through. Because Maryland, when you open the jaw, it gives you a groove. And sometimes suture gets trapped. But in needle holders, yes, even in the Maryland also.
We have
same.
to have 2 needle holders.
Ideally, one is the assisting needle holder. Assisting needle holder doesn't have lock. You can only press it. And active needle holder has a lock. So either you can use 2 needle holder or you can use 1 needle holder and 1 Maryland. And then you can do the suturing.
So we have to hold it like this. This is down.
Yes, this is down,
Up.
up. This is the way you have to hold it. When you close it, index finger should not touch. And you should develop ambidextrity. Needle holder has to be used in both the hands. Sometimes when you are doing left-sided hernia surgery, then you may need to close it by the left hand.
But how to press the needle by the upper jaw? The lower jaw will interfere with it?
No. Suppose this is the needle, dropping like that. You will go with the partially open jaw and bring the lower jaw below the needle. Can you see now? And upper jaw is above, and see, it is pressed. It is aligned up. So you will bring the lower jaw you will not touch, you will bring it below the needle, and upper jaw is pressing, and then automatically it will be aligned up. This is very simple because this is endo-ski needle most of the time. Ski is a game which they use to play over the eyes. So if it is like that, and if you press, automatically, you see, due to the physics it becomes, because dimpling, and then it becomes erect. Tissue itself will make it erect. And then, because in laparoscopy there is no one who will, with the hand, will hold it. So you have to do
So
something.
you prefer the ski?
A ski needle is most intuitive needle in laparoscopy. Why? You know, one of the disadvantage of the curved needle is that to take it out you have to rotate. Other disadvantage is that curved needle can be dropped inside the abdomen only up to 22 millimeter in the size. Just like yesterday it was 22 millimeter needle, so we put directly the curved needle.
Through 10.
Yes, but if the needle size is bigger, like sometime when you use for myomectomy, 35 mm needle, and then if it is curved one, you have to go percutaneously. It will not go through the cannula. But if you make endo-ski, then even up to 35 mm needle, it can go with the cannula. And in the bigger endo-ski needle, you can do the better suturing for valve closure, for those things. So that we will discuss once we will learn the laparoscopic suturing and knotting. At that time, you will master those things. There will be no problem. So thank you very much. Just 5 minutes. The people who want to pray, they can pray also. And then we will start after 5 minutes.